as we've seen, more use of antenatal steroids, we're starting to see that the late preterms sometimes will have hypoglycemia after that. And then CPT1 deficiency is very controversial. So that's common in our Inuit population. There's about 70% of the babies that we have born 70% of the Inuit are affected by this mutation. It's debatable whether it actually causes hypoglycemia, but it's been left in. Now, what about a critical sample? You'll hear us talk about drawing a critical sample, and we've said if the blood glucose is less than 2.8, and there's a reason for that. I'm a big believer in keeping things simple, using the KISS principle, if you've heard of that. So keep it simple, stupid, right? If we throw too many numbers at people, it gets very confusing as to whether or not, for compliance. So are we using 2.6, 3.3, 2.8? In the statement, though, we made a decision, and I'll show you why in a moment, but we made a decision to go, we're drawing a critical sample under 2.8. Okay, and I'll get to that in a minute. But suffice to say, point of care glucose uses whole blood. Laboratory measurement uses serum, and I'm going to show you the difference between them in a moment. But what we want in a critical sample is you want to, first of all, confirm the glucose is low, okay? Because there can be error. Then you want to, get a bicarbonate level, because the metabolic acidosis could be consistent with a inborn error. Ketones are important. If there's no ketones, that could be due to either a beta oxidation defect in the liver for hepatic metabolism of fatty acids. It could also be hyperinsulinemia, a lactate insulin, growth hormone, cortisol, free fatty acids, plus or minus carnitine, depending on where you are in the world. If you have a high incidence of carnitine transporter deficiencies, you may want to include carnitine. We don't typically do that here as an initial workup. Now, here's the reason why we wanted a level of under 2.8. So, as I mentioned, we have been measuring glucose, for over 100 years in newborns. But here's the problem. Due to glycolysis, okay, of red blood cells, so breakdown of sugars, whole blood tends to be about 10 to 20% lower than plasma. So the reason that this is important, and the reason why we were forced to use 2.8, is because if you take 20% of 2.8, that's another 0.55. So what we don't want to have happen is that, you do a great job overnight, you see the sugars 3.1, and you say, oh, I better do a critical sample. And the bedside nurse says, well, what do you need? And you bring out your standard sheet for critical sample, you tick the box, and they say, oh, well, this will require a macro sample. We have to do a poke, right, into a vein. You do the poke, 20% above 3.1 is 3.7. You get a cortisol that's 50, you get a sugar of 3.7, and endocrinology says, we can't interpret this, right? So if you go under 2.8, if you're 2.7 or less, when you draw the sample, you're far more likely to have a consistent blood sugar from the lab that would also be low and allow interpretation of these results. And I mentioned a little bit about continuous glucose monitoring already. Now, what about developmental delay? One of the first studies that looked at this is by Alan Lucas. Alan Lucas, this was an unusual study for him because he made his name in neonatal nutrition. And you probably have seen that name come up before in nutritional literature. But what he wanted to look at was what happens if you use, what level of blood sugar is important. And what he found was over the first 9 weeks, if you had multiple episodes of blood sugars under 2.6, this became associated with developmental delays when looked at 18 months and 8 years of age. And it correlated with the number of episodes, so that it wasn't really until you got to greater than or equal to 5 that you started to see impacts on development. So if you've ever wondered where the 2.6 comes from, I believe it's actually this study. And it really suggested that 2.6 is or less is a dangerous, or sorry, under 2.6 is a dangerous level if you have it too often. So that's where that comes from. Now, back in 2017 and 2018, or sorry, 2017, McKinley did a follow-up of the glucose gel study, so the Sugar Babies trial from 2013. And what he wanted to look at was, he wanted to look at how do these babies do? Okay, what happens in the long run if they're having, with if we're trying to avoid low sugar. So in the Sugar Babies trial, they gave glucose gel and placebo, and the goal was to avoid a blood sugar under 2.6 for the first 7 days. And what they found was when they looked at having a treatment goal of over 2.6, this was not associated with neurosensory impairment at 2 and 4.5 years of age. Now that's important. Now it was associated with poor executive and visual motor function if they didn't meet that. If the ones that fell below 2.6 persistently, they had that. But what's also interesting, and I'll just tell you what the study showed, was that if you looked at, and this wasn't really commented on much, if you looked at the placebo group and the intervention group, and you looked at their long-term outcomes, a large number in both groups had some degree of impairment. 90% of it was mild. But one of the questions that you have to ask is, why do both groups have, even though there's no difference between them? So they said, well, there's no difference in neurosensory impairment at 2 years and 4.5 years. Why do so many of these babies have neurosensory impairment at all, even if it's mild? And just to throw it out there as speculation, I think it may have to do with the fact that in the Sugar Babies trial, which had about 500 or so patients, what they did was, again, it was for the full 7 days, it was 2.6 or above. But we know that normal sugar at 2 to 3 days is 3.3. So were many of these babies mildly hypoglycemic for days on end? That's the question that I think people are asking about why there's still some impairment. Wickstrom in 2018 did what I think is the largest study. Looked at 101,000 babies. I think this was out of Sweden. And they've got great research out of Sweden because they have a population database. And what they did was they said, let's try to avoid under 2.2, and let's try to keep, so under 2.2, that's really bad. But our goal is to keep the sugar above 2.6. And what they found was that those kids that failed this and had sugars under 2.2 had poor neurological outcome. So they found 2.2 was more the threshold at 2 to 6 years of age. They also found, and I'll show you the slide in a second, but they found that both early, under 6 hours, and late hypoglycemia had an impairment, or had an impact. So if you look at cognitive developmental delay, so the first column is early hypoglycemia, the second column is late hypoglycemia. Once you adjust for confounders, which is the second column in each, what you can see is when you go to the bottom, cognitive delay had a adjusted odds ratio of 3 roughly, and it was 95% confidence interval does not cross 1. And the adjusted similarly 2.54. So you're about 3 times as likely if you have blood sugars under 2.2 in the first 7 days of age. Out of 101,600 births, you're more likely to have cognitive delay. Motor delay, once you adjust, is not significant in either early or late, but any developmental delay is significant. So clearly, going back to what I said originally, how do we define hypoglycemia? You can pick a number, but I think the real answer is looking at a whole bunch of things. To me, what I take out of this at this point is under 2.2 recurrently is bad, because that gives you a 3-fold risk for adverse developmental outcome. Trying to keep the sugar above 2.6 at least for the first few days, that makes sense to me. But I've got questions about if I use 2.6 for the whole first week, am I still predisposing some kids to adverse outcome? And I'm happy to tell you that in our own institution here, back in, I think it was 2017, we switched, or 2016 possibly, we switched to say at 72 hours, we go 3.3 and above. So that's sort of the rationale behind that. This was an interesting study. I can tell you, and this is somewhat, this was an exciting time. So November 2019, we published the Canadian Pediatric Society statement. I think it was December 2019, after Hot Topics in Washington, I got an email from a neonatologist in Canada threatening to send a letter with dozens of neonatologist signatures on it, demanding for the takedown of our statement because it was too aggressive, based on the hypoexit study. Now, the hypoexit study had not been published, but it was presented at a meeting called Hot Topics in Washington. And here's what, so this was a very much anticipated study. And what they were doing in this study, it was a randomized multi-center non-inferiority trial. Instead of using 2.6, they were using less than 2 millimoles. Sorry, I shouldn't say 47 millimoles. They compared treatments of less than 2 millimoles per liter and 2.6 millimoles. So either our goal is above 2 or our goal is above 2.6 or 2 or more or 2.6 or more. And sorry for the typo. And they had 4 subgroups. So they picked their at-risk babies, late preterms, SGAs, LGAs, and IDMs. And then what they did was they did Bailey scores, and at 18 months, the scores showed no difference. So that was it, according to this neonatologist. They've shown no difference. It doesn't matter whether you use under 2 or under 2.6. And they made an argument that if you look at distribution of babies that have blood sugars at about under 2, far, far fewer. So they were saying, oh, we can just do one screening glucose and then we don't have to check again if it's 2.1, 2.2, 2.3, it's fine. So that's what I was told. Now, you can imagine after spending 3 years trying to create the statement, it stressed me out a little bit. The idea that a month later I'm being told I need to take it down. However, there were problems with this study, and it's very important that you know what the problems were. So for one, it wasn't a superiority study, it's a non-inferiority study, just showing their equivalent. The problem in this study was they chose a very, very specific population. These were extremely low-risk babies based on the inclusion criteria. So they excluded any babies with severe hypoglycemia and high risk. 50% in both groups of this multi-center study never had a second low. Okay. The mean glucose in the two groups was actually 3.2 and 3.4. And it wound up in the end being underpowered. So they were trying to find no difference, and they didn't have the numbers to show differences. Okay. So there were multiple problems. But the other problem was more severe and frequent hypoglycemia occurred in the low threshold group. Okay. So what they actually showed here was that if you pick babies that are very unlikely to have hypoglycemia repeatedly, and you use different thresholds, but they don't have hypoglycemia, their outcomes are the same. So they didn't actually show that babies who have 4 episodes under 2 versus 4 episodes under 2.6 are the same. They actually just showed if you make it such low risk that we're not going to see hypoglycemia, your babies who aren't hypoglycemia don't have impairments. So anyway, we responded to the author in question and said, we don't think this study adds anything because they excluded too many real life babies. And that was the conclusion. And this we already talked about. Right. So this is what Charles Stanley has shown about treating the babies with congenital hyperinsulinism aggressively. Now, what about our recommendations? So the CPS, and sorry, that should say 3.3, not 3.5 for CPS. So the CPS recommendations in 2019 were 2.6 and 3.3. The AAP was 2.5, and at 72 hours, they had nothing to say about it. By the way, the AAP, that was published by Adamkin back in 2011. So their statement's now 13 years old. They're coming out with a new one though soon. And the Pediatric Endocrine Society, as you can see, they did say 3.5 at 48 hours. And what the CPS said was, and this really summarizes, I think, where we're at. It remains difficult to define neonatal hypoglycemia using a single glucose value. The AAP says current evidence does not support a specific concentration of glucose. And the PES even said hypoglycemia cannot be defined as a specific plasma glucose concentration. So I'm sorry if that leaves everybody scratching your heads, but what they're really trying to say is that, again, it's not just a number. You have to look at the totality of the presentation and symptoms and so forth. Now, what about the local Manitoba experience? So following the PES statement and following a change to 3.3, this spurred some research. Now, Fabiana may or may not remember, but when we decided to go to 3.3, there was a fair bit of pushback. There was a lot of concern by my peers that we were going to see the NICU flooded with babies that had hypoglycemia. Okay, because we've now said they have to be over 3.3. So you're going to get all these kids at 4 or 5 days of age coming in post C-section that can't go home because their sugar's 3.1, 3.0. So we decided to do a study and look at what happened over time and look at the consults. And actually things didn't go as we thought they were going to, because we agreed that for persistent hypoglycemia, we would have an endocrinology consult. And so we did find, when we protocolized it, the consults went up. I think there were 55 consults overall following the change. And the reality is, most presented with hypoglycemia in the first 72 hours. So it makes sense. If you have an endocrinological cause for hypoglycemia, chances are it's going to present before 72 hours. You're not just going to appear, right? So that concern that we're going to have all these surprise guests arrive at, this time wasn't founded, because if they were going to come, they came early. Most of them were, or 50% were IUGR. We are the weaker sex for 3 of us in this room. 75% were male. 90% were diagnosed with hyperinsulinism. So although we always check the growth hormone, we always check the cortisol level, it's far and away hyperinsulinism, which is the most common. Now, we treated 50% of the 55 consults were treated with diazoxide. And this is a very, very important point. Once you start on diazoxide, the median duration of time that they will be on it is 91 days, 3 months. So in terms of talking to families, you have to let them know it's going to be a long time. There were 2 that developed pulmonary hypertension. I've included that because there was a black box warning from the FDA a few years ago saying that there's a association between pulmonary hypertension and use of diazoxide. We implemented a screening protocol for all babies who were being put on diazoxide to have a screening TN echo. And we found 2. The 2 that we found, that what they had in common was that they were both LGA, so they weren't in the IUGR category. And the other thing that both of them had in common is when you dose diazoxide, you dose it on, there's a range from 5 milligrams per kilogram per day to 15 milligrams per kilogram per day. Both of the babies that developed pulmonary hypertension were on doses above 10. So we really try to dose between 5 and 10 if we can avoid going over 10. What we also discovered, though, was if you had used a threshold of 2.6 for the first 7 days, you would have missed 13 out of 55 infants, because they had sugars ultimately that were persistently between 2.6 and 3.2. What that says to me is it lends credence to the idea that there are babies that we would never would have seen these kids, and they would have been at home with sugars of 2.7, 2.8. Are these the ones that are developing long-term problems? It's just something to think about. And some of them were treated with diazoxide. So I think very interesting. So options, these are just reminders. If you have a hypoglycemic infant, the first thing you need to do is give them glucose. What's the second thing? Glucose. And third, glucose. So never forget, that's the first thing to address. Feeding, we can do all sorts of fancy things with our feeds, and we can give them more volume, we can stretch the volume out, make it continuous, we can change the concentration and add things to it, make it hypercaloric. There's glucose gel, there's IV dextrose. Glucagon, I've never used. Never once have I ever ordered glucagon, but I know in Toronto they love it. And when I talk to my colleagues in the East, they're always shocked that I've never used glucagon. Disease specific, so diazoxide antagonizes insulin, octreotide, growth hormone, and hydrocortisone are effective treatments, but we don't typically. There are centers that use hydrocortisone. I haven't seen very many use octreotide or growth hormone, unless you're growth hormone deficient. This just very quickly, this is from the Canadian Pediatric Society statement. I've highlighted in the middle there, I won't, in the interest of time, we won't go through it all, except to say when you're giving dextrose gel, you must give it with some milk. Okay? It doesn't work as well if you just rub it in the cheek. And just as an interesting tidbit, when you give dextrose gels, you're actually giving exactly what you would give in a bolus. Okay, because 40% of a 0.5 mil per kilo dose of dextrose gel is 200 milligrams per kilogram of dextrose. Same thing that's an IV of 2 mil per kilo and of D10. We'll just skip that. So what about glucose gel? We just went through that. The Sugar Babies trial I talked to you about briefly, it was back in 2013 by Debbie Harris. And I probably quote this trial more than I quote almost any other trial, because I mean, it was a lot by neonatal standards to enroll 513 patients is a pretty, or 514 is a pretty good study. And the primary outcome was avoidance of a blood sugar of less than 2.6 after 2 treatments. What they found, in case you're not aware, was treatment failure was roughly 50% less. So the placebo was 24% treatment failure versus 14% dextrose gel. When you looked, though, at admission to an ICU, there was no statistical difference in admission of these babies to the unit. So giving if anybody says to you, does dextrose gel avoid admission? The answer is no. But if they say to you, does dextrose gel avoid admission for hypoglycemia? Purely, the answer is yes. Okay? Because that's what they found, was it was about 50% less admission if it just looked at hypoglycemia. Why did you not see a difference in admission rates overall? The answer is actually very simple. The answer is because they had other things that were leading to admission. So they might have been very severely growth restricted, so too tiny for the ward. They might have been extremely large and had tachypnea, RDS, TTN, because infants of diabetic mothers will have higher rates of RDS. So if you look at the overall admission rate, no different, but for hypoglycemia, it makes a difference. And as a bonus, there was less formula used at 2 weeks of age and in the hospital, 13% versus 4%. The reason for that was because if you're not hypoglycemic, nursing and medicine would be promoting more breastfeeding. But at the time, back in 2013, if you were hypoglycemic, they'd say, get that baby some formula. So then the family started using formula and they got accustomed to it and they'd feed after discharge. So the take-home message is giving dextrose gel decreases the number of babies admitted to the unit for hypoglycemia, and secondarily may improve breastfeeding rates. So to me, that's a win-win. And then this is what I've alluded to. You can see that the 2-year outcome of the Sugar Babies trial, this is what I was saying to you, that 38% overall in the dextrose gel group versus 34% had some degree of neurosensory impairment. About 90% in both groups were mild. But again, we've talked about why. We do fast prior to discharge. We typically do 5 hours. Our goal is, of course, 3.3. And that's the idea, is that if a family falls asleep or they're on a long drive and they can't, for whatever, get a feed in, you want to make sure there's a margin of safety. And now in the last 20 minutes, we're going to move on to neonatal hyperglycemia. So again, we're going to start with a definition because we need to figure out what exactly is hyperglycemia. And one of the things that I'll be very quick to point out is we don't treat our babies the same way we do us adults. if I was gonna measure your blood glucose, I get a fasting blood glucose, right? So I would never say to you, if you had a sugar of 8.9, I would never say, well, we need to get you insulin. I'd say, well, did you eat recently? You'd say, oh yeah, I had a burrito for lunch with a milkshake. And I'd say, okay, well, that's not fasting. We'll get a fasting. So our numbers that we use, it's just important to remember, these are not fasting numbers. But so various definitions are used. Point of care glucose, which we know is going to be lower, okay, than a serum. 6.9 or a plasma glucose of 8.3, that reflects that 20% variability. Clinically important hyperglycemia is said to be 10 to 11.1. Okay, that's generally what most people think of. Glucosuria is not reliable in LGANs. That's an important point. They spell bicarb, they spell glucose. So you can't use glucose as a measurement in LGANs. And if you look at I took this off of, at the bottom here, you'll see glucose level 5.2, 3.6 to 11. This is the reference range that is for one of our neonates. So the lab would certainly say above 11. This is hyperglycemia. Oh, I'm missing, something got deleted there, sorry. In one of the boxes, these are all the different types of reasons why babies will have hyperglycemia. There's a lot, okay? TPN itself, lipids may cause it. Neonatal diabetes, infections, stress, hepatic insufficiency, asphyxia, drugs such as dexamethasone, surgical procedures, okay? If you need a partial pancreatectomy, right? These things can all lead to hyperglycemia. Oh, LGAN, sorry, it was hiding there. So being an LGAN in and of itself, we know that these kids are at risk of hyperglycemia. Now, why? And the truth is, and don't let anybody tell you any differently, we don't know, okay? Now, Fabiana might know, because she's very bright, but I don't know, okay? If you go to the literature, there's lots of theories, and we're going to go through some of the theories and what people think is going on. But at the end of the day, we really don't know for sure what all the reasons are, but we'll walk through some of the reasons that people think. So the first is an impaired insulin response. So this is back in 1998. This was a study looking at 56 ELBWs from days 2 to 6. And what they did was they increased them over time to 12 milligrams per kilogram per minute of dextrose infusion. Typically, a normal baby needs 4 to 7 milligrams per kilogram per minute. And that's our baseline requirement, right? So they went up to 12. And what they found was a little under half of them became hyperglycemic when they did this, okay? What they found was hyperglycemic infants had baseline levels of insulin. And when they started cranking up the dextrose infusion, what they found was of the 23 infants that became hyperglycemic, endogenous insulin went up from baseline in only 15. Okay, so that left really 8. So there were 8 babies out of the 23 that didn't really see a rise in their insulin for whatever reason. So this led to a theory, again, a theory, that one reason why babies who are one reason why LGANs have a tendency towards hyperglycemia is because in some of them, they don't appropriately increase their insulin levels as dextrose levels are rising. And then this was another interesting study that suggested it has everything to do with dysregulation in the liver. So it has to do with hepatic glucose production. So I'll draw your attention. So this is from Sweden. I love quoting Sweden. This is an old study from '94. So these were all babies under 30 weeks. And what they did was at the start, on the y-axis, they've got glucose production rate coming out of the liver. And then plateau 1 is infusion of 1.7 milligrams per kilogram per minute of dextrose, which is low, right? And you can see that hepatic glucose production, when they were receiving very little glucose via IV, was high. Okay. Then for phase 2, they went up to 6.5 milligrams per kilogram per minute. So the upper range of normal, meaning they're really giving them all the sugar they need for the most part, okay? And look what happened. In most of the babies, there was a precipitous drop into plateau to almost zero, okay, but 1 or 2 milligrams per kilogram per minute endogenous production. But in one patient, glucose level production went up. And in another 5 patients, it came down, but was still almost at a normal range. So this led to a theory that for some babies, it's an insulin problem. For some babies, it's the liver's not responding appropriately. The liver should be shutting down glucose production, but it continues in the face of adequate supply. And that's what's leading to higher glucose. Then another study comes out, and this one I'm just going to say you're going to have to take my word for it. I don't understand the rationale behind this, but this was a very interesting study because what they did was they said, why is it that it appears that some babies, once we start intravenous lipids, develop hyperglycemia? So, we're fine on day 1. Like, think about your 25-weeker. Normal glucose day 1, day 2, day 3, you've started TPN, their sugars start rising, and then you're on insulin. And so they wondered if it had something to do with the lipids. Okay, so they did this study where they used a polyunsaturated free fatty acid, which is intralipid, which is something we're familiar with. Clinolaic is a monounsaturated, and glycerol is just, one of the precursors of glucose. And what they found was when they looked at measures of gluconeogenesis in terms of micromoles per kilogram per hour of glucose production, you saw the greatest increase with intralipid. So I'm beating a dead horse in this comment, but we don't know what it is about the lipid. But provision of lipid, which is necessary for a proper metabolism, because you need a balance of protein, energy, fat, will have in some babies the consequence of also elevating blood sugar. And then this one has to do with stress. And I find this study very interesting. So this is way back in 1979. Many of you, or if not all of you in the room, were not around back then. But this was published in Journal of Pediatrics. And what this did was they looked at 30 infants, 12 boys, 18 girls. And they said, let's look at small babies, 700 to 1559. And they differentiated them as to whether or not they were stressed. Stress was defined, do they have respiratory distress syndrome and pulmonary disease? And so what they said is, let's look at kids with pulmonary disease. And what you're seeing here is the dark line are the stressed kids. The dotted line are the kids without stress. And what they found was on the y-axis, you're looking at glucose in milligrams per deciliter. Stressed neonates in panel A had a much faster rise in their glucose. And when you looked at cortisol levels in the dark line, that's panel C, you can see that the kids that are not stressed, they don't have respiratory distress, their cortisol levels are low. The kids with stress, cortisol levels are high. Now, is this a chicken or the egg? Well, I don't know. But high cortisol levels go with high glucose levels. So if you have a 25-weeker with a bad chest, who has a lot of inflammation going around, their cortisol levels high, they're going to tend to have more hyperglycemia. Then they looked in the second part of the study, they looked at those with hyperglycemia versus those that didn't get hyperglycemia. And of course, what they found was these are the kids in panel A that get hyperglycemia, and their cortisol level looks almost identical. So it rises linearly with, or in sync with your glucose. So this showed that cortisol is linked in preterm babies with stress to hyperglycemia. So this is the so-called metabolic stress. And then just briefly, because this is as rare as hen's teeth, if you know that expression, permanent neonatal diabetes mellitus, there's also transient. They all have to do with mutations in potassium channels in the beta cell of the pancreas, which leads to decreased insulin secretion. We have seen here in the last few years, there was a transient one that I recall. I don't think that one was permanent. This is a very rare condition, but just to make you aware that, that this entity does exist, with transient being more common. Now, what about outcomes? this is an important thing to quickly go over. Thankfully, again, had I had 2 hours, and I'm not complaining, Iman, you're still online. No, not online, but in the there was a recent systematic review done. This is from 2022 that looked at outcome for preterm infants with hyperglycemia, and it looked at mortality. So this is the first one is mortality, which shows you, because in the forest plot, the diamond is to the right of the middle, number one, that babies with hyperglycemia who are LGANs do have an increased risk of mortality. This is an association. It doesn't mean that it's causative. One could say that this just reflects that they have more stress. Okay. However, in other outcomes, and I always like looking at adjusted for risk factors. So any grade IVH higher with hyperglycemia, severe IVH higher, any stage ROP very significant, 0.001, severe ROP highly significant, although the adjusted, sorry, is not. When you go down to things like other things like neck is not significant, late onset sepsis not significant, but one of the important things is disability, because people have wondered about risk of disability, especially if there's an increased risk of IVH, increased risk potentially of PVL, although in this study they didn't find an increased risk of PVL. There doesn't appear to be solid evidence. All I will say is you can go to the literature today, you can look up disability and hyperglycemia, LGAN, and you'll find a study or two that will say that they're at increased risk of developmental impairments. We don't seem to see, when you look at the totality of it, any certainty with that long-term impairment. All right.
Well, sir.
I just wanted to conclude with some exciting things coming. So this is our current guideline for management of hyperglycemia, management in the newborn. The exciting thing is, so Dr. Ruth over here, who is the medical director of St. Bonaventure. You are a medical director.
Yeah, I've met.
Oh, you've met them all. Sorry. Well, I didn't know if they knew that was your role. So.
Oh, yeah, okay, again.
So anyway, she's medical director over at St. Bonaventure Hospital. And we're over there, it's been very, very nice because there is an order set for managing hyperglycemia, which the nurses can follow. And what I'm showing you here is what it's based on. And the good news is we are trying to bring it here, and we will bring it here. It's just, it's challenging. So the definitions, if you haven't figured out, I always like to start with definitions. So this is right out of our guideline. A normal blood glucose, again, non-fasting, is 2.6 to 7. We talked about, oh, I've been made a liar. I said 5 to 7 milligrams per kilogram per minute. Our guideline says 5 to 8. And prams, of course, it's a little bit higher. Now, we consider starting insulin when the blood glucose level is greater than 8, and certainly if it's over 10. But here's the magic. So this is what the order set at St. B is based on. It's based on having a suggested start for when you're where your glucose is, and then a sliding scale, essentially. This is my final slide, so I'm just going to spend a minute on this, just saying where things stand. This is for our fellows, and I guess for Chelsea too. I don't know if you know this. Where things stand is we had proposed that at HSC we would, for any baby on insulin, we would, much like we're doing for saturations, take a laminated card with the sliding scale, put it on the bed, and say, please initiate insulin at, if their sugar was 11, we would say 0.04 units per kilo per hour, and adjust insulin as per protocol based on the sliding scale. That's what we wanted to do. Pharmacy does not want us to do that. They said over here that that would not be acceptable to simply say as per protocol. So we're in negotiation on this, because the whole point is we're trying to avoid having you guys call to the bedside for a baby that's having really fluctuating sugars, every hour through the night to write another order, go up to 0.04, go down to 0.03, go up to 0.05. This should be doable because we are doing it at St. B. So anyway, that concludes the presentation. I've left 5 minutes in case, well, there can be questions or bathroom breaks or both. Any questions from anyone in the audience?
Yeah,
Yes.
so you said regarding dioxide.
Yes.
Treatment, but like, would it be, is it like good to give them, give dioxide in late preterm or like preterm population?
Yeah, that's a great question. So we don't use it in our preterms. We wait for them to be term. I never say never. I'm sure somebody's gonna tell me we used it in a 34-weeker. But in general, we use it for term. We also try to avoid using it within the first week of life. Yeah, we do try to avoid that. We've stopped incidentally doing the pre-echo before we start diazoxide because we found 0 pre's. We found the 2 that were post starting that had some pulmonary hypertension, but none, there's no way to predict which ones were gonna get it, other than having that dose above 10.
And endo's getting really not wanting to use it in the IUGRs. I don't know if you talked about that either. Supposedly they're even higher risk than other kids. That's what they told me last time.
Because I think there are studies that which shows that there is increased risk of neck in babies who got dioxide.
Yeah, so that came out of 2 places. So there was an FDA warning about that. And then there was a study published by Gabriel Eltiet and others in Quebec at Montreal Children's that also suggested there may be an increased risk of neck. It's not convincing at this point. I think that, like with anything, we have to weigh risk and benefit. You know, if you've got a baby who is getting poked 6 to 8 times a day for weeks, right? You have to weigh that versus, do we start the diazoxide? Because if you've never seen it used, it works really fast. You know, like often within 1 or 2 doses, the sugar stabilize. You know, so it does work, but I appreciate you want to avoid, I mean, of course, nobody wants to see a case of neck. But we have not, to my knowledge, I don't recall a case of neck. We had 2 with pulmonary hypertension. But so I think again, it's about using it in the right population. Like, would I use it in the 29-weeker with persistent hypoglycemia? No. You know, but a term infant who's 2 weeks of age and getting poked continuously, I'd consider it.
And diuretics,
Yeah, and we give thiazide diuretics with it. Yeah, because the theory about the pulmonary hypertension is that diazoxide causes fluid retention. The fluid retention congests the pulmonary vasculature, which then leads to secondary pulmonary hypertension.
Go ahead.
No, go. I was gonna say, I have a question, it's less about the, I guess, medical outcomes, but just, I would love your thoughts on using developmental outcomes, as a research endpoint, given how, like, nurture-based developmental outcomes can be. And so, I went, as you were talking, pulled some of the studies you were talking about to see how they try and, like, account for that. And a lot of it's a very, like, crude SCS measurement, which is going to vary from jurisdiction to jurisdiction, because I think the assumption is that if you are from poor SCS background, that your developmental outcomes are going to be worse between the absence and intervention for early childhood education. So long story short, have you ever been satisfied with the way that developmental outcomes are evaluated in a study, given the nurture influence and how that nurture influence may or may not be accounted for in a study population?
Well, I mean, that's a big question. I mean, to say ever, I'd have to go and look at the individual studies, but what I would say is that is the problem though with multi-center studies, looking at developmental outcome, because to your point, if you've got, you know, an imbalance of socioeconomic status between 2 cities, you know, and then you find that there's a difference, how do you know? I mean, you can still, this is Chelsea's domain, not mine, but I mean, looking at outcome research, but you try to control for all of that stuff, right? And match, you know, the levels of, you know, postgraduate, you know, experience and maternal
Are you
education.
talking about hypoglycemia or hyperglycemia?
She's saying in general, to try to,
Like, I might look like the Kempen study does a good job at putting out like what they had included, like measure SCS, and it's a population based, but that's also problematic.
It's actually not problematic.
Well, it, like, when you're using a population based measure to reflect an individual, like.
There's actually really, really robust data that shows that area level measures of socioeconomic status perform almost as well as individual levels of socioeconomic status.
We should have such a good conversation on this afterwards. We're having this debate in Ontario with the Ontario marginalization index and like some of the like statistical issues with applying that at an individual. But yeah, okay.
That's very good.
I have a master's in epidemiology.
That's why I said,
Yeah, he's so.
see, that's why I said she would be the person. I have a meeting that I have to get to, but I'm gonna take one more question. Well, you have a question?
Yeah, actually, I want to thank you about this informative and interesting session. I have two questions, which I know that we have no time, so just I will ask them shortly. So once we diagnose the baby with hypoglycemia and we admitted the baby, we need to start feeding. Do you have a preference of the mode of feeding? So bolus, bumping, or continuous? Do you have any preference to start? Should we start with continuous first or bumping? Or...
You know what, I cut this out of this. I didn't think I'd have the time to talk about it, but there is a study that was published in the last, I think it was March of 2024, that looked at exclusive breastfeeding with hypoglycemia combined with skin to skin care. And it showed that a halving with breastfeeding alone of, I believe, repeated hypoglycemic measurements if you were to breastfeed versus formula feed. So I don't see why we can't start with bolus feeding, promoting breastfeeding. I think that's the way to start. I think that if, you know, I'm a big believer, I mean, it depends, right? Like if the baby was seizing, you know, I'd probably feel differently. But I think for the baby that's admitted with just, you know, a couple lows, not managed with dextrose gel, I'd start with bolus feeding, get an IV in, and promote breastfeeding, and then back off and go to continuous or semi-continuous if I still couldn't get the sugar up.
Okay, thank you. Also, I think this is another question, but it will take a long time. Do you believe that the interval that we can keep the baby hypoglycemic, is it like 30 minutes to 1 hour? So we are asking to check after 30 minutes the blood sugar, which sometimes like came less than the acceptable. So the baby, hypoglycemic for 1 hour or more. Is it acceptable, or we need to make it like shorter?
Okay, so
Shorter than half an hour?
no, he's saying shorter than an hour.
Half an hour.
No, I know what you, anyway, what I was gonna tell you is, we can thank the poor rhesus monkeys for what I'm about to tell you. So the best data we have on hypoglycemia, and I'm talking about persistent hypoglycemia, is that if you take rhesus monkeys and you put IVs into them and infuse insulin and force them to be hypoglycemic continuously, in order to create consistent brain injury, they need 5 hours of persistent hypoglycemia to create consistent brain injury across all animals. So if you look at the hypoglycemia injury literature, it appears that, you know, you need 5 hours. So the question that has often come up to me is, you know, what if a baby is hypoglycemic on and off for the first 24 hours? And the answer I usually give to the people is, as long as they were treated appropriately. Because remember, when you're checking the sugar, it's at one point in time, in a moment. So presumably, you know, if you give dextrose gel, the sugar for the next 20 minutes may be at 3.5, 4. And then when you check it again after 30 minutes to an hour, it comes down. But it's not been down at 0.8 or 1 the whole time, most likely. It will go up, then it comes down. But the ones where I would get very worried is babies that you're seeing that people are not acting. So the sugar is 2.1, they give a feed, but they don't follow our protocol. Then the sugar is 2.0, and they say just feed again. They don't follow the protocol. Because of the slower enteral absorption, I don't know what the sugar would be. But I think as long as you know you're responding to it with glucose gel or IV therapy, we have a little bit more wiggle room.
Thank you.
Anyway, yeah, I'm gonna hand over to Chelsea. Sorry, I ate up 5 minutes of your time.
It's all good.
Oh,
Brandon and I have a discussion about area level versus individual marker events yet. If she's out degreed me.
well, all right, enjoy.
Thank you.
Yeah, I don't later after, after the year. You will have to flag out.
I can just log in on my web.
Yeah.
To my email,
Sure, yes.
cause I brought my computer, but then I forgot that I needed a fancy thing to attach it to the,
To reconnect to the.
I'll just do this.
And we'll have to. We have to use the link that we send you,
Oh, are you relogging in? Is it another link?
yes.
Oh, I'll let you do that.
I mean, everyone please log into the link there. You can do it from your calendar. Sorry,
Have you seen it? Marty and,
everyone who's joining virtual, please log into the link that we sent for Dr. Chelsea. Thank you.